start the recording. Let me just tell you that the topic of today's talk is who will benefit versus who will pay, reconciling the irreconcilable dilemmas of genomic medicine. Kathryn Phillips, thank you so much for joining us today.
Yes, good morning. Can you hear me okay?
Yes.
Okay, because my internet seems to not be as strong as I would hope. So if you have trouble hearing me, just put in a chat and I'll see what I can do to fix it. But let me share my screen. Okay, are we good for the screen?
Yes, yes, we are.
Yes.
Yes.
The screen.
We can see your slide.
Yes.
Yes.
Okay. Yeah, see, I'm having trouble hearing you. That's why I'm wondering whether people are hearing me.
Yeah, so we've been able to
let
hear
me proceed. Hello, everybody. As Paul said, we're going to talk about who will benefit versus who will pay, reconciling the irreconcilable dilemmas of genomic medicine. Okay, so today we're going to talk about why ethics is integral to genomic and precision medicine, even for a health economist like me. We're going to talk about why and how genomic medicine raises additional dilemmas on balancing stakeholder perspectives so that we can have policies that are both ethical and efficient. So that brings up issues like who should have access, who should pay, what should we be paying for, and whose perspective should drive the policy decisions. I'm going to provide two examples, one on Alzheimer's disease and one on multi-cancer early detection tests. And just to clarify, because we use a lot of different terms, I'm going to probably use terms interchangeably, although there are differences between these various aspects of precision personalized medicine. We have genomic medicine, we have genetic testing, precision medicine, which is now typically used as an overarching term, as opposed to personalized medicine, precision health, which brings in prevention in particular and digital technologies, and then population health, population precision medicine that brings in more of a public health perspective. I was thinking about that most of you are at Columbia, and several years ago, I had the fortune of spending a 1-month sabbatical in Mount Sinai and came up and gave a talk at Columbia in person, which was fun. I think, Paul, we met at that time, and I had some time to do fun things like go to Central Park and hear the music there in Central Park. And this is a photo from Central Park. So I finally remember my time in New York City, even though it was the hottest summer on record. It must have been about 100 degrees the day I was there in Central Park. Okay, so at the end, we're going to open it up to discussion. So I'm going to tell you the kinds of things we might like to discuss. When we're done, I'll show this slide again at the end. But we're going to be kicking these things around about how do we reconcile these irreconcilable dilemmas. The fact that I'm an economist, so I always say there is no free lunch. Someone's got to pay. That we have the dilemma of providing more access to genomic medicine for some people or less access and being able to cover more people. That in general, if you ask people what they want it all, especially if they don't have to pay for it. and that the general tendency is to believe that more information is always better, more. But in reality, that's not the case. And then whose perspective should drive decision-making? All perspectives are important, but we can't satisfy everyone all the time. We have the issue about clinicians who have to treat the patient that's in front of them, yet they're supposed to follow population guidelines. And then the overarching issue of everyone is acting to maximize their own perceived utility, then society suffers. And we certainly have seen this with the COVID epidemic, the debates over vaccines, and should we require individuals to get vaccines because it benefits society, or should it be an individual choice? We definitely see that in genomics. So first of all, we're going to have a little fun. True or false? I can't see everyone on the screen, so you can vote in your head. But think about this as we go through. True or false? We can easily diagnose Alzheimer's disease. False. Liquid biopsy tests that can detect as many as 50 different cancers in their early stages will not be available in the clinic for several years. False. Access to hereditary cancer panel testing for underserved populations via safety net clinics is increasing, or is it decreasing? So it's actually increasing, which is the opposite of what typically happens. And then finally, most new healthcare interventions save money. And that is false. Let me tell you just a bit about our center at UCSF. Our vision is to implement precision medicine appropriately, efficiently, and equitably. We provide objective evidence with a particular focus on value, decision-making, and insurance coverage. And what we look at is how precision medicine gets implemented in the clinical care and health policy. So we focus on these three key factors for appropriate adoption: coverage and reimbursement, economic value, and clinical and policy implementation. We've been around for a decade. We increasingly try to focus on solutions as opposed to just kvetching endlessly about all the challenges. We were funded initially by a program project grant, PO1. We've since had 4 NIH grants. We just got one that's a 5-year grant from NHGRI, and we have over 100 publications. One thing that's unique about us is we integrate the perspectives of many different stakeholders. All of these groups are important to precision medicine. We don't take the side of any one group. We're not advocates, but we do try to integrate and synthesize all of these different perspectives. And we have groups you might not think of that are important, that aren't studied very much, such as self-insured employers who drive benefit packages, lab benefit managers who are the equivalent of pharmaceutical benefit managers and serve as intermediaries. So lots of different diverse groups. And this just illustrates the types of journals we publish in, ranging from more clinically oriented to more policy oriented to cancer, which of course is a big focus of precision medicine. So who should have access, who should pay, and what should we pay for? So increased availability for genetic tests worldwide, but availability does not necessarily translate to appropriate use. Let me show you availability. Clinical genomic sequencing is becoming more available globally. In the dark blue, we see countries that have availability of tests that are for exome sequencing, non-invasive prenatal testing, and tumor sequencing. These are the 3 key uses of genomics. And as you can see, we do have wide global availability. Countries like the Netherlands are leaders in this field. Australia is a big leader in genomic medicine. Even middle income countries like Mexico have availability, like Brazil. Thailand is a big leader in Asia. But of course, you see that there are wide gaps. Africa is an obvious lack of genomic testing other than South Africa. Okay, let's talk about access. One thing we've found really interesting, based on 2 studies we've done of both providers and labs, is whether access to germline testing is increasing for safety net patients. And basically, we found that access is increasing. And why is that? It's because there are labs out there that are subsidizing the cost of genetic testing for Medicaid patients through these safety net clinics. That we actually found that the greatest challenge is lack of coverage for Medicare patients. I'll talk more about that a bit later, but you may know that Medicare by statute does not cover screening or preventive services. There are exceptions, but in general, they don't cover screening. And we found that for privately insured patients, the biggest hurdle these days is prior authorization, because many insurers require prior auth for some or all of their genetic tests. We did find a lot of concern, though, that these lab payment programs may not be sustainable. We were looking at cancer germline tests. We don't know what's happening with other types of genetic tests. The biggest hurdle for safety net clinics was just getting people into testing at all. And that's because we have a limited supply of genetic counselors, and the coverage of genetic counseling is often a challenge. So the people don't get into the system. Once they're in the system, they often can get genetic testing, but they can't get into the system to begin with. Second key point, increased US payer coverage for some tests, but ongoing coverage variability. Interestingly enough, non-invasive prenatal testing for high-risk women, in other words, women over a certain age, was the fastest adopted and covered test in history. Amazingly fast entrance into clinical care and coverage, so that almost all insurers now cover NIPT for high-risk women, although there's still debate about whether to extend this to average-risk women. We are seeing increased coverage of next-generation sequencing tests, such as cancer germline panels, exome sequencing for infants in the NICU, and for rare and undiagnosed diseases in children. Variable coverage by insurers for tests such as for drug metabolism, or called pharmacogenomics, cardiovascular, such as for statins, and expanded carrier screening for women who are pregnant. Not surprisingly, there's a lot of variability across Medicaid programs because every state program is different. And within Medicare, there's variability depending on whether it's a regional decision or a national decision. You may know that Medicare is actually not a national program, in that there are regional administrators called MACs, and they do local coverage decisions for most Medicare services, and there is variation across these MACs. We see discrepancies between direct-to-consumer tests versus what is covered or recommended. For example, APOE testing, which is for late onset dementia, is provided by 23andMe. I remember when I got my 23andMe test, I had to check a box that asked me, do you want to get your results for APOE? Of course, I said yes. But we just did a study that showed that these APOE testing is not clinically recommended or covered by any payers. So you have this disconnect between what consumers can get versus what is being recommended by clinical bodies, which puts clinicians in a tough position when patients come to see them and say, hey, here my 23andMe test, what do I do with them? In general, the rise of large gene panels creates dilemmas for payers. And why is that? Well, payers have a mandate to provide care that is medically necessary and not experimental. So historically, that has meant that when you do testing, you're looking at one biomarker, you have a particular reason to be looking at that biomarker, and when you get the results, you're going to do something based on those results. Obviously, multiple gene panels don't meet that, particularly when we get into, for example, whole genome sequencing, where you're pretty much on a fishing expedition. And historically, payers have wanted that everything that's being measured on a test should have demonstrated clinical utility. And again, that's something that can't be done when you're talking about large gene panels. So these panels have blurred the use of results for research use because researchers want all the data they can get versus what will be used clinically. Payers are concerned about the slippery slope of testing that becomes population-wide screening versus targeted testing to people with particular risk factors. Payers are often concerned that clinics don't have the needed delivery systems to use these tests appropriately, that patients and clinicians don't understand how to use these tests or what they mean, or what to do with the results when they get them. Payers have trouble tracking how these tests are being used because of the CPT codes not being specific enough. And something we'll talk more about later is the genomic tests often provide personal utility. Payers typically don't cover things if they provide personal utility only. For example, just knowing that you don't have a particular biomarker, and if that's not going to improve your clinical outcomes, payers don't necessarily want to pay for it, even though you personally may value that information. Okay, economics. Evidence of economic value is emerging, but with mixed results and methodological challenges. Some studies are showing that there's economic value of genetic testing, but there are large gaps in our knowledge. It's often difficult to define and measure economic value. And one key reason is that we often don't have good data on the clinical utility. Thinking about what is the comparator? Is the comparator another type of test? Is it standard of care? Is it doing nothing? What population will get the genetic test? And how will it actually be implemented? As we were just talking about the personal utility aspect, how do we value that and quantify it as part of an economic evaluation? Excuse me. And then for family members, with germline testing, that has an impact on family members. So you have cascade testing. You have the issues about whether family members want to know the results of genetic testing by one member of the family. Then we have the issue of affordability versus value. These two concepts are often conflated. Affordability is, can we pay for it? Typically measured using budget impact. Value is, should we pay for it? typically measured using cost effectiveness analysis. These have typically been done independently, and therefore they don't provide the information we need, given that frequently we need to know answers to both of these, not just one. We are seeing increased willingness, though, by policymakers to consider both. I think the best example of this is the ICER Technology Assessment Group, of which I'm part of, where they look at both affordability and value, as well as clinical outcomes. Another issue that we're looking a lot at now is that benefits may accrue to different populations inequitably. And this graph illustrates how that could be the case, where you can have, say you're comparing two therapies to standard of care. And you can have a situation where the therapy provides benefits pretty much equally over populations, and therefore the average benefit is a good measure of what's happening. But the second part of the figure shows that you can have the average, but then a wide variability that's incorporated into that average, so that some populations really benefit and some do not. And that's often not examined in CEAs. My final topic for today is emerging tests for population screening, where we're seeing seismic shifts for coverage, cost, access, and disparities. Alzheimer's and related dementias has become one of our center's focus. It's definitely a very important area. Let me just show you some numbers here. More than 6 million Americans are living with Alzheimer's. This is just going to rise to 13 million. 1 in 3 seniors dies with Alzheimer's or some type of dementia. You probably know the debate over Aduhelm, and aducanumab is the generic name, the new drug for Alzheimer's. Lots of headlines about the FDA approving this drug despite the lack of definitive clinical evidence. And the company started out with a $56,000 a year price tag. This drug has to be taken for many years. They since dropped that price, but it's still a very expensive drug given how many people could take it. And Medicare raised premiums, and they said that this was the reason. There's some congressional inquiry into fixing this problem. So we have been looking at the issue about Medicare coverage, CMS coverage. And CMS has issued a draft Medicare National Coverage Decision for this class of drugs. It's for the entire class. That means not only Aduhelm, but other drugs in the pipeline, of which there are several. And basically, Medicare was between a rock and a hard place. Usually when the FDA approves a drug, Medicare covers it. There are exceptions, but it's pretty rare. However, in this case, there was so much debate about the clinical utility of this drug that Medicare did not want to cover it based on the evidence. So what they're going to do, if this draft then gets finalized in April, is to require coverage with evidence development. That means that the company will have to have clinical trials that test the drug in order to get additional data. This will undoubtedly take several years. Medicare does use these CEDs, not that frequently, but they have used it a number of times. It's rare for Medicare to then ever withdraw coverage. So this pretty much gives us time to get more data. The data is really unconvincing. They could withdraw coverage at that point. But this whole debate has raised a lot of issues we're going to see more and more of, you know, how do we balance these new innovations with the need to provide interventions that have definitive clinical utility and that are affordable and of value. So just to illustrate one thing we've been looking at, if someone asks you today, do you sometimes lose your train of thought or feel a bit more anxious than is typical for you? Well, I don't know about you, but ever since COVID, I lose my train of thought and am more anxious all the time. But the interesting thing is that this is one of the screening questions used by Biogen as to whether you would be eligible for their new drug. Well, then that would be a lot of us, right? So we have been investigating this issue about how is eligibility for these drugs going to be determined. We think there's been less attention on how to actually diagnose patients at risk for Alzheimer's and who might benefit from these new therapies. Data shows that 1 out of 5 patients may be misdiagnosed. And one thing I did not know until I started working in this area, even though my mother had Alzheimer's, was that there is no single test for cognitive impairment or for dementias. That many times what is used are these memory tests, which obviously have some subjectivity associated with them. You can do things like PET scans and spinal tests that are invasive and expensive. So we really don't have good, inexpensive, non-invasive ways to figure out who has cognitive impairment and therefore could benefit from interventions. We don't have the system capacity, enough neurologists to do this. So one thing that we're seeing emerging, which we hope is going to be one solution, are inexpensive, non-invasive, blood-based biomarker tests, where you can look at people's blood and find evidence of early Alzheimer's markers and therefore be able to intervene. Another one of our favorite topics these days is multi-cancer early detection tests. You may have heard these called liquid biopsy. This is considered one of the top breakthrough technologies in recent years. A simple blood test for cancer has huge benefits. It could provide earlier detection. It's non-invasive because it's a simple blood test. You can do it rapidly. It probably will be accurate. It could be less expensive. One blood test can detect over 50 cancers. And actually, there's a test now on the market. Now, it will cost you almost $1,000, and no insurers are covering this test right now. But you may not know that only 5 cancer types have recommended screening tests. So there are a lot of cancers where we have no screening test available. So, and greater than 50% of cancer diagnoses and deaths occur in these cancers without screening tests. So potentially huge benefits, but many questions. Will they truly be accurate enough? Or you can have a problem with false positives. What are the benefits versus harms of earlier detection? We've seen for other cancer screening tests that earlier detection is not always better. It doesn't improve people's outcomes because lots of people have cancer. You will die with this little thing in your body. The question of whether these tests will substitute for current screening tests or be a complement. Right now, they're a complement, they're an addition. So we're talking about still doing mammography, colorectal cancer screening, prostate cancer screening, lung cancer screening, but just adding these tests. So will payers cover, where perhaps everyone over the age of 50 will get one of these tests every time they get their annual well exam. So this could upend the traditional cancer screening model where we screen by cancer type, mammograms for breast cancer, etc. And obviously this raises a lot of complexities for economic value. How are you going to do a model that examines all of these different potential cancers that could be screened? You really can't. And then how do we best incorporate patient and provider preferences for these tests? There was an interesting article about, will we all soon live in cancer land? New technologies promise to help us discover more cancers in time to treat them, but they also risk ushering even the well into an all-encompassing kingdom of the ill. As I mentioned, we probably all have some type of precancerous or markers in our bodies. And if we know that, is that all going to make us feel worse because we know that we've got this thing in our body and maybe it's cancer? And is that a good thing or not? This was an interesting study. Participants were asked about a cancer screening test. They were warned that years of research have unquestionably shown that the test does not extend life or reduce the chance of death, and that the test could lead to unnecessary treatment. 51% still wanted this test. So now we are back to how we're going to reconcile all of these things. Who should have access? Who should pay? What should we pay for? Whose perspective should drive policy decisions? And I wanted to be sure and thank my team. And with this, I am going to open it back up to discussion.
Great. Thank you so much, Kathryn. So the floor is open for discussion. It's nice if people turn their cameras back on for this part of the seminar. And if you would like to ask a question, you can either turn your camera on and wave at me, or
and if you'd like to put something in chat, that's fine too, and I can just read it.
You can,
especially given that the internet is not great.
You can put something in the chat, or you can use the raise hand function at the bottom under reactions by clicking on reactions and then clicking on raise hand, which gets you that little hand in the upper left-hand corner, and we'll know that you have a question to ask. So while people are pondering their questions, Kathryn, let me start by asking you your sense of where the payers are on this question of what new genomic test is worthwhile paying for.
Now, I didn't hear that whole thing. I'm sorry.
So let me try again. The question is, where do you think the payers are Okay, maybe that'll be
Yeah, let me try that.
yeah,
Okay.
in terms of sound. So where do you think the payers are with regard to how to evaluate which new tests, for example, the 50 cancer screening test, and whether they should be paying for them, given this balance you were talking about between discovering what might be conditions that would never progress to seriously requiring treatment, but once they're diagnosed, people are going to seek that treatment and physicians are going to provide that treatment versus, potentially life-saving interventions for cancers that currently can't be detected by standard screening approaches. Where are they and in their thinking about this, and how do you think this is going to be resolved?
Yeah, that's $1 million question. So we just published a paper. It just came out last week, and I didn't show it, in Health Affairs, that lays out what will be the challenges and potential ways that payers can think about these tests. And we're actually doing a study now where we're interviewing payers to understand their perspectives on these tests. And it's going to be a challenge. As noted, I think there's going to be a lot of patient and clinician demand for these tests, because everyone's going to want, if it's covered by insurance or the price goes down, I think pretty much everyone, or not everyone, but a vast majority of people are going to say, sure. I mean, I personally, when I think about me as an individual, I think, yeah, why not get the test, right? Because what if there's something in there? But when you look at it from a population perspective, I mean, look at even things like mammography, where we have over screening. We detect things like DCIS, which is not really cancer, but we call it cancer and people freak out. Now, let me give you another example, personal example, where I had my routine mammogram. They called me afterwards and said, we see a little something. We want you to come back right away. So I went back right away. I didn't think to ask them how much it was going to cost to take another look. And I walk in the door and they say, that'll be $1,000 to take another peek. And I'm like, really? $1,000? And it was nothing. But because people are so concerned about missing something, we then do more than maybe we need to do.
And do you think this demand is going to be, do you think this is going to be simply irresistible, that the payers are simply going to be compelled to go along with this? Yes.
Sometimes when there's enough demand, payers go along. But remember, there is no free lunch. Payers then will raise premiums to pay for this type of thing. So, people think that they're just getting it for free, but, they're not. So there is a trade-off, but I do think these tests, given that there already one on the market and there are more coming, that it's going to be just a landslide where, once it gets going, boom, it's going to have to be covered. But they may restrict coverage, though. For example, only with people with particular pre-cancer risk factors or people of certain ages. I see something now in chat that's related to these multi-cancer early detection tests, as well as expanded carrier screening, APOE, have been introduced by labs rather than demand. The benefits to commercial entities drive the introduction. They're creating demand for their own products. How should that enter into the debate? Yes, definitely. We published a paper on lab business models and how they're changing. And absolutely, we see labs driving demand, and these are for-profit labs. Their goal is to make money. That's what you're supposed to do. We see academic labs suffering because they can't provide testing at the same low cost as these commercial labs, and they can't subsidize testing as much as some of these labs are doing. So you do have these commercial labs driving demand, and it's hard for guidelines, clinical guidelines, to keep up. So yes, for example, things like APOE, where a lot of people getting those results, but there's really no good evidence that those results are helpful. Now that may change with these new drugs coming out, because it used to be there was nothing to treat Alzheimer's. You could alleviate symptoms, but you could not treat the actual disease. Now that we are developing the ability to treat the disease, in other words, the amyloid plaques in your brain, then this may change, and APOE may become something that becomes more commonplace. But absolutely, good point.
Kathryn, I don't know how much you've looked at international comparisons, but it seems to me that there are countries that do a better job resisting the kind of imperative that the last question asked about. And that does get one wondering, what is it that, for example, makes the National Health Service in Britain, or to a lesser extent, perhaps Canada, the provincial plans, able to resist these kinds of demands, whereas we have so much trouble here doing that?
Yes, absolutely. And I mentioned ICER. ICER is the one group in the US that is essentially trying to do what other countries do using a government agency. We used to have a technology as government, the OTA, if you remember that. But the US is, a very diverse governmental system. And you may recall the death panels isn't popular in the US, but we're seeing ICER take on a very large role. And there's a huge emphasis on reducing drug costs. As you probably know, if you heard Biden's recent speech, State of the Union speech, drug costs was front and center. The only way you're going to reduce drug costs is to have systems like other countries use, where you have someone reviewing the evidence and making these tough decisions. There's pressure now to reinstate an Office of Technology Assessment in the US that would do such things like NICE does. We'll see if that goes anywhere. I see something in chat.
Yeah, we've got a question there. How does the length of time, this is Elizabeth Carney, how does the length of time a consumer is on a particular payer product affect payers' decisions about genetic testing? It seems that often genetic tests may not create a clinical benefit for many years. What time frame are payers considering?
Yes, that's always an issue in the US, because the average person only stays on a plan for 2-3 years, with the exception of places like ICER and, of course, Medicare. So yes, so payers are looking at a shorter time frame, which is why budget impact is often very important. How much money do payers have to pay up front for somebody who may not be with them? Now, this comes up a lot with newborn screening. Should payers be paying for whole exome or whole genome screening of newborns, where the information could be useful their entire life. But the fact is, who should pay that bill? So we also see this with gene therapies, where we have curative gene therapies for diseases that previously could not be cured, actually cured. But these are millions of dollars. So people have proposed various mechanisms, like make it like a mortgage, right? Where you buy it when you buy a house, where you're spreading out the payments over time. So in this case, so that no one payer has to foot the bill. But it's definitely a big issue given the high cost of some of these new drugs that are coming out.
Other questions or comments about any of these issues?
Okay, I see one on digital health platforms. Yes. So
yes. Go ahead.
Yeah, digital. So of course, digital is a big now on various sensors. So, you know, the best known of this would be like a Fitbit, but now there are all kinds of sensors that people can use to detect things. And there's even like pills you swallow and they stay in your stomach and they sense what's going on in your body. So definitely there's a lot of interest in this sensors and monitoring of various things going on in your body. Metabolomics, the people that monitor themselves every day for all their things that are going on. Payers right now aren't necessarily paying for this because the clinical utility hasn't been well defined. But I think there's a lot of interest because there are uses of genomic information that actually probably are quite helpful. But it's a new area, just same as with artificial intelligence.
So Kathryn, we're
On figuring out technology because of the input data being biased, and therefore what you do with what comes out could impact diverse populations differently.
Elizabeth, did that answer your question? Were you asking about something more closely related to genetic testing with regard to digital platforms? Okay. Elizabeth says that was helpful. Other questions? All right, so Kathryn, you're frozen on my screen. But seeing no other, whoops, and now we've lost you altogether. Okay, well, thank you all for joining us today. We'll be back on April 11th with Ben Berkman from NIH. Ben takes the controversial position in some quarters that people should not have the right to decline to receive genetic testing results if testing has been done, and I anticipate that that's what he's going to be talking with us about in April. And Kathryn, it looks as though we have you back just in time to thank you very much for your presentation. We're sorry about the technical problems, but I think the presentation came through, and the question and answers were great, and we're very, very much appreciative. So look forward to seeing everybody next month.